would like to thank our sponsors, Genentech, Biogen, and Scholar Rock for supporting MDA's SMA Virtual Learning Series. My name is Jessica Hubbard, and I am the Manager of Community Education Department at MDA. We're thrilled to have you join us for today's virtual learning session on orthopedic care in SMA. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We'll have a Q&A session on August 22nd from 4 to 5 p.m. Eastern with today's presenter as well as other presenters from the MDA Virtual Learning Series. I would now like to welcome our speaker, Dr. Howard. Thank you so much for being here today. We're excited to hear about orthopedic care as it relates to SMA. I will hand things over to you.
It's my pleasure, Jessica. I've always liked to support the MDA and happy to be here to talk about spinal muscular atrophy and the orthopedic care of that issue. I'm just going to share my talk with you. And as you said, I'm at what was formerly called Alfred I. DuPont Hospital for Children. It's now called Nemours Children's Hospital in Delaware at the Alfred I. DuPont campus. So just a little correction there because people are getting a little confused with the change in the name. But I wanted to talk to you about orthopedic aspects of spinal muscular atrophy, but in particular, I wanted to talk about how in this new age of disease-modifying therapies like gene therapies, gene splice modifiers, and the like, how has that affected the development of orthopedic problems, and how does it affect its treatments? That's what I'm going to talk about today. And I don't have any disclosures, but I would like to acknowledge our Nemours Muscle Clinic here in Wilmington, Delaware, with our new neurologist, Dr. Manish Kumar, who just joined us, Robert Heinley, our pulmonologist, has been there long-standing, Eileen Shea from Rehab Medicine, our PT, Amanda Erb, and coordinator Willis Brown, as well as myself. So we've got a great multidisciplinary team. We meet weekly to see kids with SMA and other neuromuscular diseases. So spinal muscular atrophy, as this audience knows, is relatively common in my world, although only 1 in 6,000 to 1 in 10,000 patients will have that. It's an autosomal recessive disease with that's progressive, and it's the anterior horn cells of the spinal cord which are primarily involved. What happens in SMA is the survival motor neuron protein, that gene product of the SMN1 gene, has been affected and involved. And this is what's responsible for that anterior horn cell degeneration and the disease manifestations, such as things like scoliosis, muscle weakness, and the like. The SMN2 gene is also makes this SMN protein, but only about 5 to 10% of normal. And the number of copies of this gene is important. And we'll talk about that later in the talk. So the more copies of this gene you have, the more of this protein, the SMN protein you have, and typically the better your motor function. And in general, if you have less than 3 copies, then you have a more severe phenotype, and more than 3 or more copies, less severe. Disease-modifying agents like nusinersen, otherwise known as Spinraza, risdiplam, and onasemtogen avaparvovec, gene therapies have really changed the landscape for this for the musculoskeletal aspects in SMA as well as overall function, and it's made things quite exciting. We traditionally have classified SMA as in 3 main types in childhood and type 4 in adulthood onset, and it's based on when the disease symptoms onset. So type 1 is considered the acute infantile stage, where you have the onset's at birth to 6 months, and those are kids who are very severely involved, who typically have poor truncal and head control and are very dependent for their care and wheelchair ambulators. Kids with type 2 are considered sitters with good head control, and with the onset of disease-modifying agents, many of these children have also retained some ability or gained some ability to walk. although still with a lot of assistance. Type 3 are, have an onset that's later, about age 2 to 15 years. And those kids are primarily ambulatory, so they can walk, although may require wheelchair ambulation in their adulthood. And the orthopedic management of those kids is not that controversial, but for the other types, it has been controversial in the past based on variable outcomes in the literature. A little more about the disease-modifying agents. Nusinersen is typically delivered by lumbar puncture, and that modifies gene splicing, and that makes more SMN2 gene available, and then thus more SMN protein. And this has been shown in studies to have improved survival and motor development. There's an oral agent which has a similar mechanism called risdiplam, which also has some good results. The gene therapy is Zolgensma, replaces the defective SMN1 gene, and there have been some dramatic improvements in function with that therapy. So these agents have really changed the way that orthopedists like me have think about SMA, as we see kids getting more functional and actually having more issues related to things like hip instability or scoliosis. And so it seems to be, bringing these things to a forefront. I wanted to just touch a little bit about Hammersmith Functional Motor Scale. This is if any of you out there have, of SMA, you probably had this scale applied to you, particularly if you're taking any of these disease-modifying agents. We use this scale to really assess your function and how you're doing on these agents or with any other therapy, or just looking at how the disease progresses over your lifetime. This is a validated score, and it's been developed for SMA. So we use it quite a lot in our clinic as well. Now let's get into some of the orthopedic aspects of SMA. I alluded to scoliosis. That's probably one of the most common things, where the spine is curving, and we'll talk about that in more detail. That can affect seating imbalance, can impact standing and walking impairment for those who have that function. And there's been some controversy about whether or not it has a primary effect on pulmonary function or respiratory function. With respect to the hip instability is common in SMA and can lead to painful arthritis without treatment, but not in all patients. It can also affect standing and walking impairment. Fractures, and we actually had a talk about this not too recently in the Quest magazine, looking at fractures, bone fragility, and bone health. And, so fractures are very common, and they can really impact your ambulatory ability and also cause discomfort. Fractures of the tibia and the femur bone are the most common. For those who walk, like traditionally kids in type 3 and would have lower extremity muscle contractures, which impact their ability to have an efficient gait pattern. With disease-modifying agents, some kids with type 2, as I mentioned, are also having this ability, and so we're having to think about those patients a little more carefully with respect to how we might help them achieve better ambulation. And certainly hip instability, as we talked about. Standing impairment is typically an issue in kids with type 1 and type 2, and a lot of our kids will use standing frame to help with bone health, socialization, encourage core strength and those type of things. But lower extremity muscle contractures of the hip and knee most commonly can really affect the ability to get into a standing frame, for example. And issues related to hip instability with pain and scoliosis can also impact that. But again, with these new advent of disease-modifying agents, attitudes amongst orthopedists, I think they're really taking notice. Not everybody is like me, who've been sort of doing this for the last 20 years and have always really focused on kids with SMA. But because of the variable results in the literature, there has been a shift away in the past from thinking about orthopedic management other than scoliosis. But the new functional changes and improvements have really put a spotlight on these orthopedic aspects and challenge us to reconsider treatments of the past and these controversies. Let's talk in more detail about scoliosis. It's very common in the previous literature, the lower your SMA type, the more likely your risk was, but most of the studies looking into that were very small. We've done a recent study here at Nemours, which I think sheds a little more light on what the prevalence probably really is more truly. This has an earlier onset than kids who don't have neuromuscular diagnosis, so kids with idiopathic scoliosis. And it has been proportional to functional level. But disease-modifying agents in their improvement of function have been making an impact, and I'll show that in our research. Scoliosis causes sitting problems, difficulty with caregiving, and although respiratory decline is very common in SMA, it does have periods where it can be quite stable. And scoliosis alone or its treatment hasn't had a reliable effect, as we'll talk about. This is some of the data from our study looking at the prevalence of scoliosis in spinal muscular atrophy. And we found that if you break it down by type, we saw 90% prevalence of scoliosis in types 1, 88% in type 2, and about 50% in type 3. I thought it was kind of interesting that even in type 3, who are quite functional and ambulatory, would have that higher risk of scoliosis. So that was kind of interesting. It really feeds our knowledge about how often and who we should do surveillance on to catch scoliosis at an early time for early treatment. The age at scoliosis onset overall was about 8 years old, but it had an early onset with type 1 versus type 2, and type 3 was a little later. We look at the risk factors for scoliosis and SMA. We looked at our cohort of over 160 patients in our Nemours system, which had scoliosis, and looked at their risk factors for that. So if you look at things like SMA type or Hammersmith score, their ambulatory function, whether they've had hip displacement or not, or disease-modifying treatments, pretty well everything was a significant risk factor. The only thing that really didn't come out in the wash was the number of SMN2 copies, which is kind of interesting given that, it is sort of been accepted that SMN2 copies is a pretty decent proxy for disease function, but maybe not with respect to orthopedic aspects. But if you look, this is looking at all these risk factors together. When we actually look at those risk factors that are not dependent on each other, those ones that are independently contributory to the development of scoliosis, really two came out, and that was and these were two protective factors. So having a Hammersmith functional score greater than 23, that's around the threshold where someone can not walk, but can do some crawling, can sit independently and can do some crawling. So that's kind of that cutoff there. So if you had a higher Hammersmith score, and the other protective factor was if you were using disease-modifying agents. And so that was quite interesting. I mean, that's kind of what we were hoping to see, was that these disease-modifying agents would have a positive effect on preventing orthopedic manifestations like scoliosis treatment. Let's go into some of the treatments for scoliosis. Bracing often comes up, and I get a lot of questions from parents and patients about bracing and how it can affect seating support. It certainly can affect seating support very well, but does not seem to improve scoliosis development in of itself. So it doesn't prevent the progression of scoliosis. And in some kids who are quite involved from a respiratory point of view, having that bracer around your chest, kind of further restricts the expansion of your lungs and your chest cavity, and may further exacerbate your respiratory dysfunction. If you're going to use a brace, sometimes people need it to help augment their sitting function in a wheelchair. I think that's a reasonable thing to do. I use a soft type orthosis rather than some of the hard plastic. You need to often have an abdominal cutout for a G-tube for those kids who need G-tube type feedings, and also to allow for abdominal breathing. But, regardless of bracing or whatnot, once you get to about 50 to 60 degrees, if you reach a certain age, around 8 years old, 8 and above, these kids are typically indicated for surgical intervention. So I want to go into that for you right now. The goals of scoliosis surgery and SMA are not so much about respiratory function, they're about comfortable seating, about ease of caregiving, about social interaction, being upright, in your chair or, and looking at a person on their same level, has social benefits too. Decrease pain, and also, of course, we want the benefits of any surgery to outweigh the risks. And in these type of surgery, there are risks involved, and we'll talk a little bit about that. And disease-modifying agents seem to be improving function and decreasing risk in this regard, which is really exciting. The types of scoliosis surgery which we typically do use for patients with spinal muscular atrophy include those that are growth friendly. So for kids who are quite young, under the age of 8, we would, if we needed to do this, if we couldn't sort of manage things with non-operative means, wheelchair adjuncts, maybe some bracing, then we would go to a growth-friendly constructs which allow these rods to get put in the back where they can elongate over time, often with an external magnetic field for most of them. Magic rods many of you have heard of or probably have even been treated with. And these are fine, but they do have their risks and complications as a non-fusion construct. There are some higher risks with those than the more definitive fusion, which you can see on the right-hand side, where we put pedicle screws in many vertebrae along the spine, and a couple of rods on either side, usually made of titanium or cobalt chrome. And for most cases, we'll actually instrument the pelvis as well, as you can see with those screws. And this is what we would employ for someone who had that curve bigger than 50 to 60 degrees, who was more than 10 years old. But in that in-between stage between 8 to 10, we really individualize the treatment. At Nemours, our center, we typically would go more to a definitive fusion type surgery at that in-between or tweener age, because we've got some research just to show that these kids seem to do very well and have less complications than going through a growth-friendly route. One thing you do have to do is for kids who are taking or adults who are taking Spinraza, you need to leave a window for intrathecal access to the spinal canal. And sorry for any of you who are squeamish, this is a surgical picture. You can see the screws here on the side, and that white patch is actually a patch of just gel foam, which is just to show where we've taken out the bone around the spine to allow for the interventional radiologist or whoever's doing your nusinersen, your Spinraza injection, allow them to have a space to be able to put the needle to get it in there. I usually put a couple of clips, one on either side as well, to give them a target. So when they look at that on x-ray, they can easily see where they need to go. Of course, your options are if you've had a spine surgery and you didn't have a window left or whatnot, or there is an option to convert to oral risdiplam, and sometimes we can even get through the fusion mass even though it's been fused over. At Nemours, we also have offered what's called a port. So this intrathecal port was developed by Dr. Miller here. You can see who's kind of injecting this little port that goes under the skin and has a tube that goes right into the spinal canal there, into the intrathecal space right away. And that space is one that would end up, I'm really sorry, someone's up here, Jessica, I'm gonna have to do this again, hang on. Someone's up here cleaning. Yeah, you can start downstairs. I'm sorry, Jessica. I told everybody I even hid away in the attic and nobody ever comes up here. But we have someone who's helping us clean the house today. We've got some guests coming over who they're going to be staying up here, so I guess she's doing that. I'm also going to silence my email because that keeps beeping. So I'm going to see if I can do that. So apologize. I will just stop my sharing for a second. I can't actually hear you right now.
Sorry. Yeah, I was on mute. I was just saying
Okay.
we can edit. If you don't want to start all over, we can cut it from there or whatever you're most comfortable with.
Um, where do we stop?
With the catheter, if
Okay.
you wanted to just start back with that slide, we could,
Uh,
um,
Okay. If you
and
think
continue from there.
that'll work.
Yeah, yeah, we have a wonderful person who does our editing, so he can work magic.
Okay. Y- You didn't mind, there's a lot of beeping and stuff there. That didn't bother too much.
Actually, couldn't hear it on my end,
Oh, you
which
couldn't.
is
Okay.
surprising. No, not at all.
Okay, I'm gonna mute this play sounds. None. Okay. All right. I'll start at the so after definitive fusion we did that, right?
It was when you were talking about the port that Dr. Miller created.
Okay, so I'll just go on from there. I've got to share again. Where are you? Such a nuisance.
It happens.
I'm like, everybody's gone. There's not going to be anyone up here. Yeah. All right. So I'll go on from this.
Sounds good.
Okay. Are you recording now?
Yes, we're good.
Okay. So for those of you who are a little squeamish, I am showing an intraoperative picture here of scoliosis surgery. You can see the screws that are there. This is the back part of the spine. And this white little patch here is just a little bit of a gel foam material which we placed over the dura surrounding the spinal cord. And this is where this is the window where the bone has been taken away to allow for the injections of the Spinraza to go into the spinal canal after the scoliosis surgery. And I usually put a couple of little clips on either side of the window just to let the interventional radiologist be able to see where they can inject the have a target for where they can inject the drug. And they've said that this has worked out pretty well for them. For those who've already had a spinal fusion without the window left, I mean, you can still convert to oral risdiplam, and in some cases, we can even get through the fusion, the bony fusion mass, and continue with our intrathecal drug delivery. Another option is the use of an intrathecal port. This is Dr. Freeman Miller, who helped develop this device, which we use at Nemours. And what this is basically a catheter that goes into the intrathecal space around the spinal cord. And it's a little bubble there you can see that goes under the skin. So instead of having to go to see an interventional radiologist, use x-rays, you can just find the bubble and just put a needle through the skin and inject the drug like you can see Dr. Miller doing here. So we've had several of our patients have this and they quite like it, but not everybody opts for this. When you're thinking about kids with and in adults with SMA, for those people who walk, you want to consider not fusing to the pelvis because a lot of times the pelvis is used in the most forward motion and gait. So you kind of throw your leg forward by swinging your pelvis back and forth. And so to fuse the pelvis in those situations can sometimes impact that. Although I must say the research on that is not completely confirmatory, but we tend to leave it out, like this kid who had SMA type 2, who did have some walking potential or walking preserved and was on long-term Spinraza treatment. With respect to chest deformity in SMA, this typical bell-shaped chest has been described for kids who have more severe disease. And this is due to muscle weakness between the ribs, the intercostal muscles. The diaphragm in SMA stays very strong. But with this intercostal muscle weakness, the ribs do sag, and there's a lack of support for the chest cavity. And we do see respiratory decline over time, which is variable. And the question is always, does scoliosis surgery help? Well, certainly straightening the spine gives you a longer chest, but it doesn't really expand your chest. We've even tried to do certain things like using little implants which hold up the ribs, and it really doesn't seem to address the primary problem of that muscle weakness. So we don't do scoliosis surgery for the chest or primarily for respiratory function, although it can have a little effect, we believe. Here's a kid who, this is courtesy of my friend and colleague, Dr. Ron Al-Hawari, who's at the IWK in Halifax, Nova Scotia, Canada. Here's a patient with type 2 spinal muscular atrophy who had this growth-friendly instrumentation and magic rods and lots of these little outriggers that attach to the ribs to keep them up. And despite that, unfortunately, over time, the chest still sagged, although the spine remained straight. And so, so again, we don't do this just for pulmonary function. Myself, Dr. Ahawari, and others looked at all the literature in the disease-modifying agent era, looking at pulmonary function in spinal muscular atrophy after surgery, and really the evidence was not fantastic. It's pretty low-level evidence, but in most cases, after surgery, decreases in pulmonary function were found, or although there may be a decreased rate of decline in some cases. But again, this was before the disease-modifying agents, so all that literature really has not so much of an application now for those patients who have been fortunate enough to have disease-modifying agents. If we look at growth-friendly surgery for scoliosis and SMA, here's a friend of mine, type 1 SMA. She's long-term nusinersen user and, doing pretty well. She had growth-friendly surgery. You can see that here. She had a big scoliosis and then had these magic rods put in quite early. See, she also had some hip reconstructions a little later on. And she's done well with this. And although she's now 13 years, these non-fusion constructs have stayed well, and she hasn't had to have any changes or revisions. So that's pretty cool. If you look at outcomes after scoliosis surgery in spinal muscular atrophy, whether they're growth-friendly or definitive fusion, there is higher risk of postoperative complications for scoliosis surgery in SMA compared to kids who don't have neuromuscular diseases, for example, and probably a little higher than for kids with cerebral palsy, which would be more common. But if you look at the impact of disease-modifying agents, we found in our studies that it had a positive impact on postoperative outcomes after scoliosis surgery. We found that although they did have some postoperative complications, these complications were less severe. They had decreased days intubated after the surgery and decreased length of stay in the ICU in the hospital. So these are all very positive impacts of disease-modifying agent use. And not to mention, the kids have been more medically fit for surgery so that they can tolerate these bigger surgeries and get those benefits. Whereas in the past, some children were just too medically fragile to undergo a scoliosis procedure. Interestingly, the SMA type, SMN2 copy number, they didn't have any significant impact on whether or not on what kind of complications or outcomes would happen after scoliosis surgery. So it was really disease-modifying agents which made the biggest effect. The need for blood transfusion was the most common complication, although I wouldn't really call it a complication, something that's expected, but it was classified under our system. Let's go on to the hip. Hip is not as commonly talked about in SMA, though it's becoming more of interest of late, particularly with the onset of disease-modifying agents. Hip instability is common in most neuromuscular disorders and highly prevalent in SMA, and as you'll see, linked to the functional level. The reason why the hips come out of the joint is due to muscle weakness. So the muscles around the hip, in addition to the bony ball and socket sort of configuration, those muscles will help keep the ball into the socket. And when they become quite weak, the ball tends to grow out of the socket. And this can lead to eventual dislocation and osteoarthritis. In the past, there was a big fervor to put all the hips back in the socket whenever they came out. This was back in the early 90s. There was a big push for this. And then, but a lot of these kids had recurrence of their hip displacement. So the hip came out of the socket again, and it became less in favor because they felt that the risk of recurrence was too high. And then a lot of kids didn't have pain. So why treat it if you're not going to have pain? But I think that those early studies really were quite small and weren't really that well controlled. So I don't think we had a really good handle as what was going on. Recently, we have had some studies which looked at hip pain in SMA in a more systematic fashion with larger numbers. And in this study from these two studies, one from Phoenix and one from Baltimore, showed the risk factors of being obesity. This is for hip pain now. Prior scoliosis surgery with fusion to the pelvis. So if your hip that's out of the joint, and then you fuse the pelvis and push it down over the ball, it can make it hurt more. Hip contractures, tightness of the muscles around the hips. Dislocated hips seem to hurt more. And if you had higher function, like having higher number of SMN2 copies or have a higher SMA type, then you are more at risk for hip pain. But this is a pre-disease modifying agent study. These studies were before this era, the current era. So we're not sure what the impact of disease modifying agents are on hip pain itself. One theory is that this higher function and higher muscle strength may lead to more pain due to the muscles putting more pressure on that displaced joint. Here's our friend I showed you earlier who with type 1 SMA, at 2 years of age, her hips looked fairly normal. They were a little bit uncovered, so maybe not normal, but they were certainly not anything that you were too concerned about. But by age 5, and then by age 7, you can see how those hips progressively dislocated out of the joint. And her hips were painless until she reached about age 12. And that's when she started to have discomfort and pain. And remember, she was taking disease modifying agents as well. Looking at what happens to the hip, you can see it sort of, the ball grows growth is directed out of the socket. It presses on the cup, which makes it flat. You can see that red flattening there and causes the hip to dislocate. Here's a child with type 2 SMA who at age 2.5, you can see she had pretty normal looking hips. Age 5, looking a little uncovered, particularly on the right. And then by age 7, these hips were well on their way to dislocate. And she ended up getting a surgery for that. And the indications for surgery in her case, she also had some discomfort. She was doing some walking and also had previous disease modifying agent treatment, although that's not a true indication for surgery, although we do take it into consideration. So how do we get the ball into the socket? We use a special plate called a blade plate, and we cut the bone. We cut out a triangle in the bone, and we tilt the bone down into the socket so the ball gets tilted into the socket. And you see the socket is still not that round, so then we use this plate, to do that. And then we want to reshape the socket, so we use this special chisel which goes around the socket and then levers it down to make it more round. We bend around the growth plates in the socket, and then we place a piece of bone in there to hold it out to place, and then you've got a round ball and a round socket and decreased pain in most cases. So here's this young girl with the type 2 SMA, and you can see how her hips look after the hip reconstruction is nicely covered and her pain went away. So the idea of this is to prevent arthritis in the long term, improve their seating, improve positioning, and perineal care. So care around the private parts. We looked at at Nemours, we looked at the risk factors for getting hip instability in SMA. We had 82 patients who had hip surveillance x-rays, which we looked at in all the SMA types. They were mostly in SMA types 1 and 2 and lesser in types 3. We investigated risk factors to see which things were responsible for the hips coming out of the joint. That would include genetic severity, SMA type, disease-modifying agent treatments, whether they can walk or not, Hammersmith scale, and the presence of scoliosis. When we looked at the prevalence of hip displacement, it kind of looks a lot like the one for the scoliosis graph. You got about 84% type 1, 80% risk in type 2, and a lot less in type 3, around 36%. And that kind of makes sense if you're linking orthopedic manifestations to function. So it makes sense that these would look fairly similar, these graphs. The age of onset was earlier than for scoliosis, and this is pretty well the same in all neuromuscular disorders. It was at about age 4 years old, and with type 1, it was even earlier, about age 3, type 2, age 6, and type 3 at age 9. When we looked at all the risk factors I talked about, we found that everything seemed to be related to the development of hip displacement. But these are all related to disease severity and function. But if you look at the risk factors that are independently contributory to the development of hip displacement, it was having a little higher SMA type, type 2, and having scoliosis. So these were the two factors that were risk factors for that. We didn't find that disease-modifying agent treatment was protective. In fact, it seemed to have a negative effect on hip displacement, and that may be because of the increased muscle strength, would actually cause the hips to have more muscle imbalance and come out of the joint even further. That definitely needs more study to further work that out. We did find, though, a Hammersmith score of greater than 23 was protective. So that was like what we found in scoliosis. So that was a good thing. So higher function, on the one hand, from disease-modifying agents may make the hip more likely to come out of the joint, but having a good function by Hammersmith seemed to be protective. So again, I think there's more work to be done there to further look at all these factors. So the question is, we know the risk factors now. Should we actually treat hip instability in SMA? The prior studies, as I said on this, were very controversial, but they were before the use of disease-modifying agents. These agents are making patients stronger, more ambulatory, and they can tolerate these bigger surgeries because they're healthier. But I don't think we know the answer yet as to whether or not hip instability should be treated definitively in SMA. We at Nemours do tend to treat kids who are ambulatory in type 3 and ambulatory type 2s. But we may, because of the increased risks of hip displacement after surgery, we may be more reactive in kids who have lower functional levels. But we take each case on a case-by-case basis to make sure we make the best decision for the patient and their family. Here's a 16-year-old, for example, who had no prior hip surgery, but did have a persistent hip that was coming out of the joint. And she did develop arthritis and pain, and she came to me for help. And we did the reconstructive surgeries we talked about. Our pain was improved. And I wonder if we're going to see more of this after disease-modifying agent treatment, and have to really start paying a lot more attention to the impact of hip displacement on function and quality of life in SMA. So lots more work to be done there. There are some newer minimally invasive procedures which we've been using in cerebral palsy. This is a percutaneous screw placement over the growth plate in the proximal femur at the level of the ball, and you can see over time this screw helps guide the growth of the ball back into the socket. And this has worked reasonably well for cerebral palsy, but it really hasn't been used much in SMA, but it may be something to think about in the future. Just almost at the end now, so looking at muscle contractures in SMA, we have tight heel cords, knee flexion contractures, hip contractures, either ones that cause you to scissor or cause your legs to be out to the side. We also have foot deformities like this one here. This is an equinovarus foot, where your foot is turned over. And we also get flat foot, we get toe flexor problems. And all these things can affect function. If you do standing, having a foot that looks like this is not going to help you in your stander. Even if you're using wheelchairs alone, having a foot that's very rigid and turned over on itself, or very severe toe walking type thing, will affect how you put your feet on your wheelchair foot plates, will also affect your ability to wear shoes. And a lot of my patients, want their feet fixed just so they can put on a decent pair of shoes. And what's wrong with that? I certainly listen to them when they ask me for these things. The contractures do worsen by SMA type and with age. And although we put a lot of focus on bracing, particularly in other neuromuscular conditions like Duchenne muscular dystrophy, I'm not sure that it has a big impact on whether or not these contractures develop or not in SMA. It may delay, it may, but probably not prevent. When we think about the foot, it's important as a lever to walk on if you're going to walk or stand. And so having a good stable foot is important for that. But you don't necessarily have to have a perfect foot to have a good lever from your foot. If you have a brace, the right brace can also help you with that. The goals of muscle contracture surgery in SMA are to improve sitting, for example, wheelchair sitting, if you're having problems with your hips, and which are impacting that, improve standing, improve walking. And the disease-modifying agents is changing attitudes with a real focus on function for orthopedic surgeons who in the past might neglect these contractures just because someone couldn't walk, which I think we need to be a little more broad-minded in that regard. A lot of kids will have so I'm just going to move on a little bit, have knee flexion contractures, which is quite common. You see here's a kid with a 10-year-old type 2 SMA who was an early nusinersen user through trials, and she maintained some walking ability, although you can see her knees are quite flexed and they're stiff in that position. And it's not just the hamstring muscles causing the problem. If you look at over time, her hip flexion has gotten the worse by a lot, and her knee flexion contractures has gotten worse as well over time. So this is progressive, some decrease in strength as well around the hip, but she's otherwise doing pretty well from a functional point of view. We use some braces to help, and that certainly helped her gait function to keep her upright. But that knee flexion, when you flex the knee like that, the ground reaction force goes behind the knee. So the force of the floor on your skeleton goes behind the knee, which causes the knee to flex. And the only way to keep yourself up is to use your quadriceps, which uses a lot of energy. So the idea is to get that knee straight. But how do we do that? To get the knee straight when there's such tightness there is difficult. You can cut the bone and extend the bone and put a big plate and screws on it, but that's a huge operation for someone with SMA, and I think the risks may outweigh the benefits there. Another more minimally invasive technique is to guide the growth. Here's some screws that went across the growth plate here in the front, and over time the growth was guided so that got the knee straight after about 2 years. This is a kid with spina bifida, not SMA, but the exact same thing occurs. And once the deformity is corrected, you remove the screw. So this is a nice minimally invasive way, which is well tolerated. And some kids can be a day surgery. We have to really think about all the medical aspects when we're thinking about surgery for any child or adult with SMA. You have to look at their pulmonary function. You have to make sure their nutrition is optimized to improve wound healing, reduce their risk of infection. And bone health is so important. So we often get DEXA scanning, look at their bone density beforehand. Sometimes we treat with bone hardening drugs, bisphosphonates, if their bone is quite soft, particularly if we need to do hip reconstructions and sometimes for spine surgery. So those are all things we need to work with our medical colleagues to help ensure these are safe surgeries and have everything fully optimized. So in summary, disease-modifying agents targeting the SMN1 gene and the SMN2 helper gene improve function in SMA and seems to improve or help prevent scoliosis treatment. So orthopedic problems, however, do still develop despite disease-modifying agents. And may, in some cases, like the hip, may make things a little bit worse with respect to pain, although this isn't a reason not to take them. Disease-modifying agent can improve the medical aspects of SMA, allowing for safer surgeries. And, scoliosis surgery, allowing us to do those type of things in a safe way, allows for improvements in function and quality of life, but probably not so much pulmonary function. And surgical decision making these days should focus on the functional goals and making sure you have the optimal surgical dose to get the best outcomes for kids. So I want to thank you for listening to my talk. I can't wait to answer your questions on the panel and hope you got something beneficial out of this.
Thank you so much, Dr. Howard, for sharing this valuable information with our MDA community. I'm also looking forward to everyone getting to see everyone at the Q&A session on August 22nd. So again, thank you so much, Dr. Howard.
My pleasure.
We would like to thank our sponsors, Genentech, Biogen, and Scholar Rock for supporting MDA's SMA virtual learning series.